All right, good evening, everybody. I'm Dr. Agnivesh Tikku. I'm a spine surgeon, and we welcome you all towards this NMOA, Navi Mumbai Orthopedic Association webinar series. We have today the extreme pleasure of having presence of Dr. Shashin Ahuja with us. Dr. Shashin Ahuja is a spine surgeon at Welsh Centre for Spinal Trauma and Surgery, which is the part of University Hospital of Wales and Landau. He is a excellent teacher. I had the privilege of working with him for a short period of time, but he is an excellent clinician, an excellent spine surgeon, and an excellent teacher. There are no words to uh, highlight what a good person he is, and it's extremely honorable to have him today. He's the current president of British Association of Spine Surgeons as well. And today we have chosen a topic which sort of intrigues each one of us. We have most common infections in spine which are tubercular in the Indian setting, but off and on we do sort of get infections which are not tubercular, and that is the time when we get into a different scenario or a troublesome situation where we do not know how to go ahead. So that is the whole aim of getting a different perspective of pyogenic spinal infections. What are the surgical management tips and how do we diagnose it and what we can do, because they behave absolutely differently from tubercular spinal infections. On the panel today, we have Dr. Sanjay Dhar, Senior Orthopedic and Spine Surgeon from Navi Mumbai, practicing in DY Patil and Apollo Hospitals, Navi Mumbai. And we have a very capable young spine surgeon, Dr. Rohan Gala, who is also working in DY Patil. So with this, may I request Dr. Shashin Ahuja to please take over. Over to you, Shashin, sir.
Okay. Thank you, Agnivesh, and thank you very much for asking me to speak in this webinar. So I'm going to be talking about spinal infections, and as Agnivesh mentioned, infections, because I've trained in India, trained in Bombay, I'm from Sion Hospital. I did my undergrad, postgrad there, and all the infections in spinal surgery we used to see there, unless proven otherwise, was TB. And the saying was anything in the spine, TB, bolo TB. That's what people used to say all the time. And then you transition, you change, and you start working elsewhere, and you see different things. So we do see TB, but a bulk of our work of infections, whatever infections we see are mainly pyogenic. TB you would see quite infrequently. So I'm based in Cardiff in UK, Cardiff is the capital of Wales. So I've got no disclosures. Agnivesh is not paying me for this talk, and neither is Sanjay Dhar, so you can be safe. It's just talking about my own cases, my own opinions. So I'll just quickly cover issues about the pathophysiology, what happens, how patients present, how we manage them, and how we plan things for them. So as you can see, in the spine, the infection could present in different ways, in different parts anatomically. So it could be in the vertebral body itself. It could present in the disc space. Now there's a common misnomer because infections in the spine are usually called discitis, which actually is incorrect because the disc itself is avascular. It does not have a blood supply. The blood supply for the disc actually comes from the vertebral body. So the infection usually is hematogenous spread. So it's a spondylodiscitis, which should be the correct term for it. You can get an epidural abscess. It could be ventrally, anterior to the cord, or dorsally, posterior to the cord, depending on where it's arising. You can get septic arthritis because the facet joints are prone to infection as well. And there are different reasons for it, and I'll go through some cases with you. You can get paravertebral collections like you do tend to see with TB, but not as extensive usually. But you can get an abscess tracking down the psoas. You can get inflammatory changes in the muscle causing pyomyositis. So these are the different anatomical variations that you tend to see when you see a patient with pyogenic infection. And we all know this. Sorry, I'm not trying to teach basic microbiology, which most of us know. Commonest is the gram-positive Staph aureus. Patients who have UTI have a higher risk of having E. coli or Pseudomonas. IV drug abusers, you do see them. They are immune suppressed and they are prone to infections and they can get Pseudomonas infection. Patients who've got sickle cell disease and can get salmonella. And of course, TB I did talk about, but I'm not going to be talking too much about TB. In fact, I would like to listen to one of your webinars about TB rather than you wanting to hear me say anything about it. So as I said, the commonest way how the infection gets to the bone or to the spinal column is hematogenous. It's arterial or it could be venous. Now, venous infections are usually in the lumbar spine through the retrograde flow through the Paxton's plexus. It could be a contiguous spread from an adjacent infection. Sometimes you could see somebody who's had an esophageal procedure done, they can have spread into the vertebra from there, or it could be direct seeding. And in that sense, word discitis may be appropriate. Say, for instance, you've done a discectomy and that gets infected and you get infection inside the disc itself. So you could get any of those ways how you can get the infection. I'll just take you back to embryology, and you may look at that and go, goodness me, that's my first year in med school. And the way the vertebra is formed, it's formed by the sclerotomes. The sclerotomes split up, and you can see the blood vessel, which lies in the middle, right? So the blood vessel here supplies the vertebra, lower half of the vertebra, and its cousin, or whatever you may call it, supplies the upper half of that vertebra. And those two are responsible for providing nutrition to the disc. And if there is any problem with the vertebra itself, the disc gets affected, the disc does not get enough nutrition. And as the disc doesn't get nutrition, it necroses. And you've seen that in TB. In TB, you will see the disc usually does not necrose because TB is a chronic pyogenic, chronic infection, whereas an acute pyogenic infection is a very rapid process. It goes through quite quickly. It eats up the bone very quickly. TB takes weeks. It's quite an indolent sort of a disease. And that's what leads to the disc getting necrosed in an acute scenario, in a pyogenic scenario, compared to a non-pyogenic tuberculous scenario. And you can see how the blood vessels, the branches going down and up from the nutrient vessel that enters the vertebral body. And that's the gist of how you get spondylodiscitis. Now, there are patients who are more prone to infections. And I have to say this, unfortunately, you can see this in the current pandemic. These are the patients who are shielding. These are the patients we are trying to look after. These are the patients we don't want exposed to coronavirus. And same thing holds true for any infection. Age is a barrier. More than 70, you're at a high risk of infection. If you're diabetic, you've got renal issues, rheumatoid arthritis on steroids, IV drug abusers, urinary tract infections or any procedures, and HIV/AIDS. So, that problem does not change because what is infection? Infection is a fight between the bug and the body. And if the bug is strong and the body doesn't resist it very well, the bug wins. And that's what's happening with coronavirus in some patients. And that's the same analogy for pyogenic infection as well. But if your body is good and can cope with the adverse event thrown at it, with the infection, it can look after itself. Patients usually present with varied symptoms, right? Back, neck pain. Of course, patients who come to our clinics who we see have back pain, neck pain for different reasons, right? Maybe degenerative, maybe traumatic, anything. They may have fever, they may have constitutional symptoms. If they've got any neural problems, they'll have neurological issues. So they could present with radicular symptoms. They could present with compression of the spinal cord, and they could have associated issues as well, maybe because of the primary cause where the infection is coming from. They may have a UTI and those sort of symptoms to go with it. But not all of these are sensitive enough to gauge that this is definitely infection. All these clustered together would make you think, and those red flags should straight away go up for you to start thinking a patient who presents with pain in the spine, has got fever, has got constitutional symptoms. That's a red flag. You'd start thinking there's something not right here, and we need to investigate this further. So common investigations, blood investigations, again, I don't need to go through all that, just white cell count, ESR, CRP, procalcitonin test is sometimes utilized. And that's mainly because if you have sepsis or multi-organ issues, procalcitonin levels will rise. We do rely on blood cultures a lot. And I'll come to that why in more detail, but blood cultures obviously help us understand what the bug is potentially. And it does most of the times. And that really would help us drill down what the problem is, help us decide what sort of treatment we're going to institute and how we're going to start treatment and what we're going to start. So all those things, for that reason, blood culture becomes quite a pertinent investigation. Imaging wise, I think the gold standard is MRI, quite highly sensitive, quite highly specific as well for infection, and it will show you changes, it will show you issues. X-rays, yes, we do them, but they're not completely diagnostic. You need to lose quite a lot of bone, nearly a third of bone, before you would gauge that this is infection or tumor for that matter. So X-rays are not diagnostic in a way from that point of view, not very sensitive. So MRI being the top, which we all utilize, I suppose there's no question about that. Sometimes you do use CT to assess if there is any the extent of bone loss, and even for post-treatment to see if there is ankylosis or fusion. MRI, I'll go back to, you may just do a localized MRI to the area, but some would do a whole spine, just look at other non-contiguous areas where you could have infection. Especially if somebody is immune suppressed, then there is a risk that they may not only have one area of infection, they may have multiple others as well. So please watch out for that and be aware of it. Just getting a whole spine MR would do you no harm, in a way pretty similar to when you treat a patient with spinal metastasis. You would do an MRI whole spine. So it's not too dissimilar. Bone scan is utilized as well, and it can show you activity. In Pyogenic, you can expect it to be very active. So it's not used frequently, but occasionally you may rely on a bone scan as an investigation. Then you look for the primary source. So you may get a midstream urine sample done. You may get a CT, thoracic abdopelvis, and those sort of things you could utilize to assess things further, try to figure out where the primary source of infection is so that you can treat the primary source, which would help the patient overall. Echo is another test that is performed to rule out any seeding on the valves in the heart. So that is something that is utilized frequently as well. Biopsy is a very, it's a little bit of a catch-22 situation. Ideally, you would like to have a biopsy. Ideally, you would like to get a tissue diagnosis. You would send your biopsy for culture sensitivity, and you may send it for histopathology, like I suppose you do routinely for TB. So not too indifferent, but unfortunately, the problem with biopsy is the yield of a positive result from a biopsy is roughly between 40 and 50% if you read different papers. And that becomes very difficult. And what happens sometimes is patients are so unwell that we start on empiric treatment anyway, even without actually doing the biopsy. Or you may start your treatment based on the blood culture. And that's why I was telling about blood culture. It's quite important. We do rely on the blood culture quite a lot. And if the effect of the antibiotic isn't as good as you want it to be, then you may reconsider doing a biopsy. And now there's a school of thought who would say that you have to stop the antibiotics for a week or two before you repeat the biopsy, or you do a biopsy in that situation. But on the contrary, there are recent studies which would say that you don't need to do that. You could still go ahead and do a biopsy despite patient being on antibiotics, which may or may not be appropriate when you're not sure whether the antibiotics are taking effect and trying to get the infection under control. So biopsy can be quite a tricky one, but if you're stuck and you don't have a diagnosis and you're not sure what this is, then you may have to rely on biopsy. So it's multiple things that you have to utilize before you make your decision, how you're going to treat. And like most of the times in our setup, because we do not have that those number of cases with TB, most of the times it is pyogenic, the infection that we see, and most of the times they are gram positive, and staph being the commonest one, and we treat them with staph specific drugs. So things like flucloxacillin, fusidic, teicoplanin, rifampicin, those sort of things is something that we tend to institute treatment. Management, non-operatively, we rely antibiotics. Sometimes we do consider immobilization, and it's more for comfort and pain, and to try to prevent progressive deformity in that segment, which I'm not sure the brace would allow that, but we know that what would happen with a period of time, you may get a kyphosis in that area. We do heavily rely on our infectious diseases colleagues or your microbiology colleagues, and we are very blessed where we are. We've got a very, very, very good infectious diseases department. They're very proactive. They work very closely with us, and they even do in-reach rounds on a ward once a week. Or if there are patients, they'll come in, they look after all the medical management. Like I suppose it's for your, from your point of view, where you have patients with TB, where your chest physicians help you, same way our infectious diseases team help us significantly. So in a way, we work in a sort of a multidisciplinary team approach with obviously the infectious diseases, the radiologist, us, maybe the microbiologist as well sometimes. So all of us put our heads together to make sure that what we're doing is actually working. We do operate like for any other condition, and operative treatment usually is to try to get a biopsy. If there is any instability or compression on the spinal cord, you would decompress and stabilize the spine. So in those situations, you would consider surgery, and where there is neurological issues, you would surgery would be absolutely indicated. So I'll just quickly run through examples and I'll stop talking about different things. I think cases are a good way to highlight issues, bring through messages. So this is a young chap who presented to me with L5S1 disc prolapse. This is my own patient. If you work long enough, you do see different sort of problems. So I don't have to blame anybody else for what I show you here. So presents with radicular pain, has conservative treatment, non-operative treatment, including a nerve block, settles his pain for a while, pain persists, and he's having agonizing sciatica. So he ends up having a discectomy, and he does well, and for nearly about 6 weeks, he's doing well, and he's hoping to return back to work at between 4 and 6 weeks, and then starts complaining of grumbling back pain. And you think, oh, it's just back pain, no leg pain, no neurological symptoms, no weakness. I go, carry on with physio, carry on with your exercises, this would settle, and with time, this should settle down. But this pain just persists, and he is generally feeling unwell, malaise, a little bit of fever, nothing major. And you go, this doesn't look right. So I sent him for an MRI scan. This is nearly about 2-3 months post-op. And you can see the early signs of infection, not early signs. This is quite clear that this is infection. And the way to recognize that is if you look at the end plates on a T2 weighted image. So the end plates on the vertebra look quite crisp and nice if you look at every level. Look at L5S1. The end plates are not clearly visualized. The end plates are eroded. And you can see the general signal in the L5 and S1 disc space itself is not looking very good. So that would make you think that this is infection, and you can see the increased signal at the back. Fortunately, did not have a wound infection, so he's pretty only 6 to 8 weeks or 8 weeks or 9 weeks post surgery, and you can see he's starting to develop spondylodiscitis. He was treated with antibiotics, and he responded very well. Initially, I started him on flucloxacillin and fusidic acid. He couldn't cope with fusidic because of his diarrhea. So instead, the infectious diseases helped us out, and they started him on teicoplanin and rifampicin. And he did very well, and he settled down eventually, like what one would expect from a spondylodiscitis. He had bony ankylosis along the L5S1 segment, and he's been pain. He has got some pain, but nothing significant, and he's returned back to work. This is nearly 2 or 3 years down the line for him. Here's another guy, young guy, who presented with spontaneous onset back pain, very fit, very active. Um, he was fit as a fiddle, and he's complaining of grumbling back pain. And usually, if pain doesn't persist, you would normally do an MRI scan. He did not have much neural symptoms. He had some intermittent paresthesias down his legs, but nothing major. And he had no other signs or symptoms to suggest that he had a problem. So he had an MRI. He had blood investigations done. His ESR was something about 45 or 50. His CRP was about 38 or 42, something like that, less than 50. Normally with spondylodiscitis or infection, the ESR and CRP are usually in triple figures. So they'll be more than 100, sometimes 2, 3, 400, especially in patients who are immune compromised. The ESR and CRP would be very high, like 300, 400 sometimes. So this guy we just treated him with a course of antibiotics because he had an epidural abscess, but he's got no neurological problems. We just observed, we kept monitoring him, and gradually his symptoms settled, and it all resolved in the sense that he had his pain settled. He did not need any active intervention. And I suspect the start of it was a septic arthritis in the right L3-4 facet joint. As you can see, the signal in the right L3-4 facet joint compared to the left. The joint, you can see the cartilage, the articular cartilage on the left side. You can't see any of that. And that's leading to this epidural abscess, which is encroaching on the theca or the chorda equina. But fortunately, he did not have any neural symptoms, and his symptoms were ongoing for quite a few weeks before he presented to us. And antibiotics made a difference to him, and he did improve quite well. Here's another one. And this patient was having back pain for quite some time, was having treatment, was seeing a chiropractor or physio, or I'm not sure exactly, an osteopath, one of them. And he was having conservative treatment with them, and the pain wasn't settling. He was having acupuncture. And when he started having acupuncture, then his pain really got worse. And at the time, we really didn't realize what was going, because he presented to us with agonizing back pain. He was very tender to touch. He was feeling unwell. He was febrile. He said he couldn't sleep. He was having real significant problems with night sweats. And also, we got a scan, and you can see in this situation, he does have an infection in the facet joint, which is more like a facet joint septic arthritis. The articular cartilage at this stage is well maintained. The left side facet joint looks good. And you can see the signal in the paraspinal muscle on the right side. It's quite, like, you can see the inflammatory change. You can see the signal change. He's got associated pyomyositis in that area, which would explain why he's in so much pain. He's been having a lot of antibiotics, and he'd had treatment with that. And gradually his blood markers settled, his mobility, his function settled. His anterior column, the discs, the vertebrae were pretty good. So he did not need anything else, and the antibiotics did the trick for him. Here's another one, a patient who was under the renal physicians having dialysis, and he presented to them with back pain, and he was having problems. And you can see on the X-ray, as I was saying, X-ray is not a very good starting point in a way to make a diagnosis, but this does help to an extent. You can see, I know it's not very clear. You can see the vertebra there. You can see the vertebra there, and you can see the disc in between. That disc looks good. Look at the height of that disc there. This disc is very narrow, and you can see some issues with the end plate. But still, it's not very clear. But it gives you an idea of what's going on. And he had an MRI scan which confirmed spondylodiscitis. You can see the increased signal in the L2-3 disc. You can see the end plates are eroded. You can see a little bit of reaction anteriorly. Fortunately, nothing in the back, no epidural abscess. And again, we did the blood tests. We did a blood culture was done, and based on that, we identified what the bug is, and we started treating the patient with oral antibiotics and IV, like to start off with IV antibiotics and then oral antibiotics, and then gradually things settle down. And this is what happens eventually. This is a sequelae of infection, especially pyogenic infection, where you get fusion, a bony ankylosis. So you can see the bony ankylosis there. You can see the bony ankylosis on the X-ray. And that way you know that the infection has been taken care of. And that's how it ends up with a bony ankylosis. Unlike in TB, where you don't get bony ankylosis, you tend to get fibrous ankylosis in TB because of the chronic indolent process. This is another one, not exactly spine, but not far from the spine. This is somebody who was presenting with low back and buttock pain on the right side. And they've got changes in the sacroiliac joint. They got pyogenic infection affecting the sacroiliac joint with a small abscess sitting in front of the right sacroiliac joint, as I'm marking out here. Again, investigated, treated accordingly, and then with good resolution of symptoms. Usually, if you treat the infection appropriately with appropriate antibiotics, you do usually get a good result, and they tend to heal far quicker than what a TB patient would be, where you need months and months of antibiotics or anti-tuberculous drugs to control the infection. So non-operative treatment mainly is antibiotics. Now the debate usually is whether you use single drug or two drugs. The debate is whether you use it for, how long do you use the antibiotics for? 2 weeks enough, 6 weeks enough, 3 weeks? Whether you give them IV, you give them oral. There are different schools of thought. Usually, we would rely on a two-drug regime rather than just a single drug. But again, we rely quite heavily on our infectious diseases team. Duration is variable, but at least 6 weeks, if not 3 months. And that would also depend on the way the patient is progressing and your clinical markers, your blood markers, your radiological markers. Based on all that, you decide whether antibiotics for 6 weeks or 3 months. To be safe, to start off, we tell the patients it may be 3 months, but if you finish at 6 weeks and everything heals up, what better? The patient's happy, you're happy. IV versus oral is another one. Some people would say you have to give antibiotics intravenous. Some would say you can give them orally. We usually rely on a loading dose, and afterwards, as they start showing improvement in their blood parameters, then we start thinking about switching to orals. Some may use the blood markers as a guidance to say that you can switch to oral with a cutoff of CRP at 50 or 60 or something like that. Some people tend to use that. There was a recent study published in the Lancet last year, which was the OVIVA trial for bone and joint infection, and they showed that oral was as good as IV, and you could rely on oral antibiotics, which does the job. Bracing is another treatment which is not controversial, but sometimes people don't believe in it. Some people believe in it. Like with anything else, if there is pain because of instability, which these patients can have, then why not brace them? It does them no harm. It just helps them. It helps their mobility, helps their function. It gives them a little bit more quality of life, so they can mobilize comfortably. So I would not hesitate using a brace if required. And there are different braces for different areas. So, for cervical orthosis, cervicothoracic orthosis, thoracic, thoracolumbar, whichever, you deal with it accordingly. Imaging is another one, apart from the initial investigation, whether you carry on doing scans. It's a bit dependent on how the patient is responding to treatment. If the patient is responding to treatment well, then perhaps you don't need to be doing MRI scans all the time. If you see they're clinically better, their blood markers are better, you may not need to do a repeat MRI scan. If the patient is showing signs that their blood markers did settle but do not want to come down or are not settling, the pain isn't settling, uh, then, and you don't have a clear-cut diagnosis sometimes with the exact bug, then you may repeat the imaging, right? And may consider repeating a biopsy. And you could do that CT guided, open, whichever way, as we discussed previously. But we don't do serial MRI scans just to see how the infection is progressing. CT scan you do perform sometimes for different reasons, and I'll show you a couple of examples later. So I hope I've covered the important aspects with regards antibiotic treatment, um, the issues with regards bracing, and issues with regards imaging as to how and when you tend to image. But as I said, we work in a multidisciplinary team in a way with our infectious diseases, the radiologists. So we discuss all this, and if there are any barriers, any concerns, any questions that things are not progressing the way we want it to, then you go back and start again. Make sure that you're doing everything the right way, and don't hesitate to do that, because that's the only way you're going to overcome this problem. So here's another example. A lady in her mid-60s presents with acute onset upper thoracic pain, which in a way is a red flag. Thoracic back pain is a red flag. Her age is a red flag. And you can see she's got localized kyphosis. You can see there is significant erosion of the end plate. Look at the amount of vertebra that's been eroded. Look at the pressure on the spinal cord. That's mainly because of the kyphus. And you can see there is hardly any room for the spinal cord itself, with some collection and soft tissue reaction around the vertebra. Perhaps not as big as what you would see in a TB scenario, but still there is a reaction around it. So this was treated with posterior stabilization. Patient did not have any neurological deficit. So there was no need to decompress. All we did was posterior screws, posterior instrumentation. Now, this was quite a few years ago, and I suppose in the current day and age, someone might think, why don't I just do this percutaneously, free, with imaging, like X-ray guidance, navigation, robotics, whatever rocks your boat. Feel free to use that. Feel free to, as long as you provide and do that operation in the safest possible manner. And you can see this is an X-ray done way down the line. And as I was talking about bony ankylosis, you can see that infections absolutely been controlled, and how that segment has ankylose now. So that shows that we've achieved a reasonably good result. She was getting pain because of instability. She was getting pain because of the disease itself. Once she's had the stability and the disease is being treated appropriately, there should be improvement in symptoms, and should help improve quality of life. Here's another one, another gentleman who is in his mid-60s, early 70s again, and he presented to us with acute neurological issues as he was having difficulty walking. His legs were going spongy and weak, and he was myelopathic, and he started developing cord compression, signs of cord compression. And he wasn't well. His ESR and CRP were in about 300 odd, and he was assessed by his GP, referred into our accident emergency department, where he was assessed by our team, and then he underwent an MRI scan. And on the MRI scan, you can see he's got a big epidural, he's got an epidural abscess. He's got compression on the spinal cord. He's got loss of alignment and local deformity with erosion of the end plate and some reaction anteriorly as well. And you can see on the actual cuts the reaction and the compression on the spinal cord. So this patient is somebody you need to address quite a few different issues. One, the general health. Secondly, the infection. Thirdly, the instability. And fourth, and most important one possibly, is the neurology. The neurology is the one which is causing him main problems. The cause for the neurology is the infection. So we've got to put all that together and bring all that together. And in this situation, we had no choice. We have to operate because the patient has got an epidural abscess. Patient has got an epidural abscess which is causing neurological deficit and which is progressive. And there is compression and compromise of the spinal cord. So you got to do something for it. And this patient had urgent decompression and stabilization. Yes, I did show a patient of an epidural abscess before, which was not treated operatively, which was treated non-operatively. So again, it is, each individual is different, each condition is different, each presentation is different, and you treat each individual based on what they have. And because the patient did not have any neurological deficit, the previous example that I showed, they did not have any surgical intervention, whereas this patient had neurological deficit and needed surgical intervention. Now, the other question comes up is timing. How quickly or how late could you operate? Um, in my opinion, sooner the better. The earlier you operate, the better. You get giving the spinal cord the chance to recover. And if you read various papers in the literature, usually they would say get on with it as quickly as you can, and potentially within the first 24 hours would give you a good outcome from a neurological perspective. At the same time, when you're operating, you could send some tissue for biopsy, which would give you a good biopsy material to give you a good diagnosis so that you can treat the patient appropriately with the correct antibiotics. Here is another example of this patient was, I think, in his early 60s, who presented with neck pain, was seen by his GP, sent for an X-ray, and you can see that there is underlying degenerative change. You can see that he's developing slight, like he's losing his normal lordosis, and there's straightening of a spine and slightly he's kyphosing there. So the alignment of the spine is affected. He unfortunately had AML, leukemia, and in a way he was terminal from what we gather at the time. So he was referred to us, and the radiologist picked up not only this, but also picked up the significant soft tissue swelling in front of the C5 vertebra, C5-6 disc level. And you can see the amount of swelling he has at that level. So he underwent an MRI scan, and an MRI scan confirms spondylodiscitis. So there is end plate erosion, there is alteration in the alignment, there is a pre-vertebral abscess, and there is some impingement on the spinal cord. Fortunately, this patient did not have any neurological deficit. But look at the rest of his spine, look at the rest of the bones, and each level, because leukemia is an infiltrated disorder, there is infiltration all along, even in the spinous processes. And in this, you got to weigh up what you can or cannot do. The patient does have infection, needs treatment for that. The patient does have neck pain, needs treatment for that. The patient does have loss of alignment of the spine, he needs treatment for that as well. But then you got to be pragmatic, what is appropriate for this specific individual. And for this specific individual, we believed at the time that we don't need to intervene, we don't need to operate. We need to treat them non-operatively. So he was given a brace, he was started on antibiotics, and the antibiotics were helping. And you could gradually see improvement in his symptoms, though it did take a little bit of time because he's relatively immune suppressed because of his leukemia and underlying issues that he had. But he did gradually carry on improving. And eventually, this is how he healed up. So he was treated in a brace, and you can see his kyphosing at that level, right? And this is him eventually, nearly about, this is X-ray was in about 3.5, 4 months after he presented to us. And you can see he's ankylosed, he's got loss of alignment, but he's comfortable. His neck pain is better, the infection's controlled, and I think unfortunately a few months later or something we lost him because of his leukemia. So we got to be pragmatic. In some other patient we would have considered. So if I go back to the X-ray, somebody like this who was kyphosing, fortunately his end plates do not look that bad on the X-ray. But if it looked worse, you could have put them on traction, realign them, stabilize them from the back, continue treating them with antibiotics, and then reconstruct the front. So you could have done a lot of different things with the patient, but for the right reason. As I said, each individual is different, each presentation is different, and you got to weigh everything up and decide what's best for the patient. And again, we were in touch with the hematologists who were treating him. We were in touch with the infectious diseases team and our radiologist, and all of us, we made a decision that this was the right thing for this patient. Of course, you got to talk to the patient as well and explain to them why you're doing that and why you're not operating. And the patients are usually on board once you've discussed things with them. Here is another one, patient who presented with acute neck pain, and the pain persisted for quite some time, and the pain was causing them problems. They were gradually losing power in the legs, and you can see here at C4-5 there is loss of disc height, there is erosion of the end plate, there is an epidural abscess. You can see the spinal cord is slightly swollen at that level. There's obliteration of the CSF. You can see the CSF up to C4 and from below C5 down, but at the level of C4 and C5, the CSF flow is affected. You can see the alteration in the signal in the vertebra itself. You can see narrowing of the spinal canal. You're not seeing much of soft tissue changes, but this is another patient with spondylodiscitis who ended up having a vertebrectomy because we needed to proceed with the decompression to decompress the spinal cord. And in this situation, we used a tricortical iliac crest graft and a plate and decompressed the spinal cord from the front, and with a reasonable outcome. This is another lady who is in her early 60s. She had 2 L4-5 decompressions done elsewhere, and she presented to us. She was referred by the local surgeon from one of our feeder hospitals. We are a tertiary center in South Wales, so she was referred to us from there, and she came to us. She was having pain. She was walking with 2 crutches, and at home and even outside, sometimes she was using a Zimmer frame. So she was using a frame to mobilize, and she had significant weakness in the legs. So she could only hobble around a little bit. If she was out and about for any longer duration, she would be in a wheelchair, and she had real problems. She was having real problems when she came to see us. And you can see that she developed postoperative spondylodiscitis. We did a CT to look at the degree of erosion in the bone, and you can see the extent of erosion. I don't think I have an initial MRI scan because the scans were done elsewhere. And she comes over and she is in agony. So we did decompression and stabilization. Now, the issue was that she had quite a big decompression, so we had to extend the decompression. You can see the decompression there at L4-5. It's quite an extensive decompression. Her bone quality wasn't the best. And rather than stopping at L1 or L2, I thought it would be better that we go and span the thoracolumbar junction. And distally, rather than just fixing into a S1, we also put some screws into the iliac wing. So we did some iliac screws, and we put screws into S1. And the plan was that at a second stage, we would have gone either from the front or the side, more likely the front, looking at her iliac crest. A side access may have been difficult for us. So we were hoping to go in from the front and strut the front so that we could get fusion. I accept that she's not in the best of alignments, and I'll come back to that later, but overall her lumbar alignment looks good. She is relatively flat. She has got a positive balance, but in that situation, I didn't want to do too much. She already had 3 or 4 operations. This would have been a 5th with me, and she had 3-4 operations done elsewhere. So this would have been a 5th operation, and I didn't want to do too much to her at that stage. I could be criticized to say you could have done more and realigned her and got her into a better balance, sagittal balance. But at the time, with everything together, we thought this would be appropriate. And I was hoping to go back from the front and stabilize from the front, but this was her virtually 3 months down the line. We had slight delays. She was due to come in for her surgery about 4 or 6 weeks after the posterior, but for some reason it was delayed. And before when I saw her for a pre-assessment, I said, before we go ahead, why don't we get a CT scan to see what's happening in the front, because NMR wasn't helping us that much. And on the CT, you can see she's nicely fused up. She's got good fusion at the back. You can see strands going down to the sacrum as well. So she was nicely fused, and she is nearly 6 years down the line. And at least for the past 4 years, I've been getting Christmas cards from her. I hope I'll have one more this year from her. So, you know, she's not perfectly correct, as I mentioned, on a lateral X-ray, but she's not far off, and she's quite comfortable. She mobilizes without a walking aid most of the times. Only if she is out and about for a longer duration, she'll use one stick. But overall, she's happy with her alignment and her function and how she's doing. Thank you. I think I'll stop there.
Okay, thank you, sir. Yes. So let's start the discussion. So I wanted to ask a few queries as a general orthopedic surgeon who doesn't do exclusive spine. So when will you, after the I'm guessing that spinal infection is just one part of your surgery. So when you do a discectomy or a micro discectomy versus open discectomy versus endoscopic discectomy, whatever is happening in your institute, the infection rate is highest in which type of surgery? Is it something like that where you have studied or where your institute has studied something?
So most of our discs are micro discs. We don't do that many endoscopic discectomies. The over how many years now? 17 years of being a consultant here, I've only had 2 patients who've had post discectomy infection. For a very long time, I thought I was great because I never had any. And then suddenly I had 2 virtually on the trot, which completely threw me off. I don't know. I would blame, maybe we changed our antibiotic policy at the time, because previously I used to give a shot of cefuroxime pre-op and a dose more after, and hospital policy changed and we were using only 1 dose preoperatively. I know quite a few of my colleagues do that. So it's not very common to have post-discectomy infection, but you can get it. So if you only had 2 in 17 years, I'm not sure how I could create a difference between different type of procedures, although I only do micro discs, that's it.
And do you remove just the fragment which is extruded, or do you go inside and do a little bit of the disc also when you do a discectomy?
Well, routinely I would go inside, because I would like to remove the loose fragments rather than just take the fragment which is outside the annulus. And quite a few times I would actually flush the disc as well, because there's always some loose fragments that come out. That's my standard practice. I know people may have different opinions on this, but I've not looked back over 17 years. So I don't see why I should suddenly start changing things around. So that's how I tend to do my discs.
Does the old dictum that too much of curating of the end plates makes you susceptible to?
I don't curate at all. I don't put a curate in. So all I do is use the pituitary ronger. That is it. I don't curate at all.
And besides this, see, my last case which got infected, there was a big confusion. So what had happened is that he was a young guy, and he was, say, around 25-year-old, a carpenter by profession. We did a micro disc, and his leg pain completely went away. And within 4 or 5 days, he went back home. But before the suture removal, he started having a lot of back pains radiating again to the same leg. So it created confusion in my mind. I got an MRI done, and the MRI did not show any infection. My bad luck that I did not do a contrast MRI at that time, and it did not show any infection, but it showed a small remnant piece of a disc, which I thought was the cause of the pain. So I started him on steroids and whatnot, thinking that this is not an infection. Now I've ruled out infection, so I know that it's going to settle down, but it never settled. And patient on a third MRI comes back after 6 weeks with a fulminant infection with all pus and everything. So that is what the confusion was. So when is the right time to do an repeat MRI? And should a contrast will always be done after post-operative for seeing a post-operative case?
No, I think that's a very good question. That's the difficulty. The biggest problem we have is delay in diagnosis. If you think about it, most spinal infections, there's a delay in diagnosis, like your case, right? And it's, and nobody could criticize you on that, saying you've done your scan. Now, but then, as I said, there's no one specific symptom or specific investigation or a sensitive information which would tell you this is it. But then you got to put everything together. And it's that index of suspicion that you need to carry in your mind all the time, that this potentially could be infection. And getting bloods done may have helped you. I don't know what the bloods were, for example, for that patient. And if the bloods were high, the MRI was not that conclusive, then you may start thinking there's something not right out here. Although in the first 2-3 days, your CRP would be raised anyway because of post-operative issues.
Yes.
Contrast, MR, our radiologists here do perform them, but they're not that keen on it. And they're pretty happy with giving an opinion based on T1, T2s and stir images. And I suppose they would do a stir image on a post-op.
Yeah, they did the stir image.
Yeah.
I even spoke to the radiologist, which normally we don't, because it was a post-operative case. I spoke to the radiologist. He said he doesn't feel that it's an infection. He feels it could be a recurrent disc or a remnant disc.
Yeah.
But
Were the bloods okay? Were the bloods fine?
The blood, basically CRP was marginally raised, but it was not grossly raised. ESR was also marginally raised. It was not 100, 200. It was just marginally raised, which is basically expected.
Yeah.
The only thing which I did was that I continued him on a oral antibiotics post-operative, which normally I shouldn't have. Now I have stopped doing that after that case. Oral antibiotics, which I continued for maybe a week or so, 10 days, thinking that it is an infection. And then I got the MRI. And maybe that is the reason the blood test never came out proper.
Yeah, maybe that's the reason then. That's
Would
why.
CT scan help in such situations? You might have end plate erosions more easily to pick up.
The MR is pretty sensitive. Like sensitivity for during.
Like he was talking in cases where you are just borderline, because I remember now Agnivesh is the spine surgeon in New Bombay. So I used to get a lot of X-rays, sir, he is getting pain. And is it discitis? So, and MRI that time is very confusing, whether it's a post-op collection there or it is a pus there. ASR, as he said, is borderline, CRP is borderline. So what would be a right modality that time? So, except yes, clinically that will give you
I personally don't have that much experience about CT. I would still have a lower threshold of repeating an MRI if the pain doesn't settle. And repeating the bloods again. Like, the symptom says a lot. Like the fact, like Neeraj is saying that the pain was persisting. That's why he did the MR. He kept him on antibiotics. And when the patient came back again, did an MR again, because that index of suspicion was there in his mind because the pain was persisting, wasn't it? You wouldn't expect that pain to be so much. Our discectomy patients get up, walk around within a day or two, they're home. Like virtually most of them are home within 24, 28 hours. They're happy as anything. They go, I've stopped taking my gabapentin, I've stopped this, I've stopped that. But to have persistent back pain after, or maybe recurrence, it's either a recurrence or infection, isn't it? Those are the two things that you worry about.
Agni is saying quite a few.
I think that if we are asking for a post-op MRI in a microdiscectomy patient, so the classical symptom would be the patient is quite well for a few days or a couple of weeks, 3 weeks, and then he starts complaining of pain. So I think if we are asking for an MRI at that point of time, by default, we should ask for a contrast MRI. And sometimes where you have taken out that disc, the collection over there may mimic a residual disc. It may mimic a collection over there. So I think contrast is a good medium to differentiate whether it's a residual disc, is it a infection, or it is just a benign, some serious collection over there.
No, I agree. Like, they would, our radiologists would suggest that as well.
I've got one question from the participants for Dr. Ahuja. Is it that bone scan, what you do you do a regular bone scan like a technetium-99 bone scan, or you do a SPECT, or you do a PET CT? What type of bone scans do you use?
Usually it's technetium-99 or a SPECT. We generally don't do PET CTs. But we don't use bone scan that frequently. The workhorse of investigation, imaging investigation, is an MR, and for monitoring we use X-rays, to see the alignment and how things are working, which is easier to manage in an outpatient scenario.
A lot of surgeons, sorry to say, do not believe in so-called radiologists doing the biopsy. They just believe that they will do the biopsy themselves. They're not happy with the yield, as you said. So what is the experience in your case? Do you sort of discuss with the radiologist firsthand that, or have you set up some certain protocols for taking the biopsy in these patients?
No, we've got about 7 or 8 musculoskeletal radiologists who do spine, and they're very good. All of them are very good. And you could go to them, like in our MDT, these cases get discussed, and most of the biopsies are done by the radiologist in our center. They'll do a CT guided biopsy. Sometimes we do them whereby they go, access may be an issue. You need to give them more sedation, things like that, or biopsy under GA, not that often. But a vast majority of biopsies are done by the radiologist, and they, they try to get good tissue for diagnosis so that the pathology team and the microbiology team don't complain that we don't have enough tissue sample, which always can be a criticism sometimes, isn't it?
Yes, true. And one very pertinent question I want to ask you, which we sort of face trouble with, especially the infectious disease specialists. Whenever you have a implant inside there, they tell you the first thing that take out the implant. The infection is not going to heal. And we know that implant is the only thing which is holding the things together. So such type of situations, how do you sort of convince the infectious disease specialists? We always tell them ki ho jayega. It needs to be there. We can't pull it out. But it's a very difficult situation. They want it out and you want it.
I agree. It's a catch-22 situation. We have that as well. But then they understand biomechanically what that metal is doing for the patient. And if the metal wouldn't be there, as you rightly say, there is no support, and there is more instability, which in a way would make things even worse. So they do grasp that, and they're pretty good with that now. And over the years, they've understood our way of working as well, like we have understood their way of working. So it complements.
Right. And in the cases what you showed, sir, there were a lot of facet infections. We don't see very commonly in our setups. So were they immunocompromised? They were drug abusers? I think Dr. Dar wants to ask a question after you answer this.
You continue.
I think those are the only 2 facet injections I've seen in my career. No, I'm not joking. It's not. No. I agree with you. Facet infection itself is not that common. Although sporadically we do see them, but it's not a very common finding, right? And they're interesting scans to see, and that is the reason I put them up. But generally, it is the spondylodiscitis, which is a common presentation. But facet infections are relatively rare, although there are a few case reports about acupuncture causing secondary facet infection. So that's something to remember. It's like a septic arthritis of the joint.
Yes, and I believe that probably at some point of time there were the gynecologists used to do the uterine prolapse colpoplexy. They used to take the stitch at L5S1 level to hold the uterus up to treat the prolapse, and that also led to a couple of incidences of
yeah, I've fortunately not seen any of those.
Yes, but yes, they were described in literature. Dr. Dar wants to ask a question, please, sir.
No, something very related means the pendulum has swung quite a bit now. The days I was a spine surgeon, we used to conserve all these infections, and now you have young studs like Rohan Gala who is wanting me to operate every infection with percutaneous thing. So what algorithm would you use? Like which ones you can conserve, which ones you can, is it the same instability principles, or you use, being an extrapolating it with an infection, you use some other modality, maybe junctional area, then or any particular area like thoracic spine or cervical, where you definitely need to operate or not wait?
No, Sanjay, that's a very good question on that point. Like, if you look at it very simplistically, most spondylodiscitis, you could treat medically. You could. I'm not saying you can. You should. But most of them could be treated medically. Of course, if they've got instability, if they've got deformity, or if they've got neurology, like, which is similar to trauma, right? It's like some trauma patients you operate, quite a few of the trauma patients you treat non-operatively in a brace. So it's not too dissimilar. The biomechanics of the spine stays the same. And that instability could be because of trauma, tumor, infection, you name it. And that is the reason one would chip in. Now, with regards the surgical indication, the surgical indication would be higher if they've got an epidural abscess. And I know quite a few of surgeons would get very twitched if they see an epidural abscess. They would go, oh, you've got to do something. But the evidence isn't there for epidural abscesses to be operated on, all of them. And there are various papers in the literature and even systematic reviews and meta-analysis which show that the data is inconclusive. But the one thing that comes through is epidural abscesses in the cervical spine tend to need surgical intervention. So I think, so just to summarize the answer to your question, again, you have to rely on things of instability for which you would stabilize, and epidural abscess where you may have to decompress, stabilize, right? But not always, not always. Again, you have to deal with each individual and their presentation.
In the X-ray, like cervical spine you showed, who had significant kyphosis, maybe 2-level destruction. I mean, would you go a little hyper, maybe do an front back, or you would just purely depend on your anterior column reconstruction? And
no, so that patient
how
who
stable
had,
is that assembly?
Yeah, no, that patient who had AML, if the patient did not have AML and had kyphosis, they would have, and if the kyphosis wouldn't correct, then you could have put them on traction for a little while. Just recently we did one, and who presented to our center with C4, 5, 6, and 5 was completely eroded. And so we put them on traction, straightened them out. Like within a week or 4 days, you could see that the alignment was much better. And then he had surgery from the back and front. Although some people would say just do the back and see what happens to the front. So not too dissimilar to the discitis lady I showed last, who I was going to fix from the front, but I just fixed from the back first. So it all depends. But in him, the problem was his underlying problem and his general health and the associated area, the areas, adjacent areas. And that's why we decided to treat him non-operatively. But if it was somebody who needed surgical intervention, if you're going to do a corpectomy, then very likely you may have ended up doing a posterior as well.
And you would most often depend on them, stretching them preoperatively on a traction.
If they are kyphosed, yes, I would. But if they're not significantly kyphosed...
Even though being a wet lesion.
Pardon?
Even though being a wet lesion.
If you're getting them acute and they need something doing, then I don't think you need to, because you'll be able to realign. But if they've been around for some time, because sometimes they're festering on some wards, especially with regards patients who are on dialysis, they don't complain that much, and the pickup is late. The delayed diagnosis makes a difference then.
Okay, Rohan, do you have a query? Unmute yourself.
Not exactly. I completely agree with what you all have said. But I still feel, the pain in discitis, especially in post-operative discitis after discectomies, is actually because of the instability that is present. I mean, by the time a lot of patients present to us, I mean, a lot of bone is eaten up. I mean, the rate at which the pyogenic infections actually progress. And so there has been a evolution in the way we now manage these patients, at least at our center while I was training up till 2019, where we are now just, percutaneously fixing them because the instability is being dealt with, and taking a transforaminal percutaneous biopsy in the same sitting. Now, as far as the sample adequacy is concerned, I think we use the kyphoplastic cannula that is there, and the introducer of that the cannula itself, we pass the same pituitary ronger through that cannula so that we get a significant amount of sample. Because I think CT guided biopsies have been a very innovative and novel thing since it was introduced, but it has always shown low specificity when it came to inflammatory or infective as compared to your metastasis or primary tumors, let's say. So If the jury allows, I can actually show you one case as to how we have, changed the way in which.
I think you can share your screen and show if you have the presentation ready.
Yeah, I have it with myself. Just one.
So
We can
in the
have a
meantime,
discussion.
while Dr. Rohan starts his presentation,
Yes.
let me just thank Dr. Neeraj for making this all happen. He's the
We are not
orthopedic-
finished yet. Wait.
No. Before, yes. But before, because I it's my apologies. I missed introducing you in the beginning. So he's the tech guy. He's the ortho guy. So he's a very pious combination of having the technology as well as orthopedics. So please, Rohan, you can start sharing your screen now.
Yes, sir. Is my screen visible?
Yes. Start from first slide.
Yeah. So basically, this was a 35-year-old female who came to us with this picture. Severe back pain, unable to, switch postures, change positions. And this is the X-ray she presented with. Those are the standing flexion and standing versus supine views of the lumbar spine. So now this was her MRI because she had a previous procedure roughly done around 4 to 5 weeks back. So clearly this, as per the norms and everything, this shows a feature of discitis. So we went ahead and she was neurologically intact. So we went ahead and we did a CT scan. Now there is a significant amount of destruction here. So basically her pain was because of the instability that was developing over time. So at least this case was treated. What we did was we went ahead, we did a percutaneous fixation and we took a biopsy from the transforaminal root, and the patient was made to walk almost on the same day or the next morning. So now, because as you said, sir, that the end result would be ankylosis of this lesion, we believe in the same concept because organism sensitive antibiotics were started. And then this was her at 1 year follow-up. This was her CT scan at 2 years follow-up, sir, where you can see it has fused completely. What was more surprising is that even the posterior lateral fusion has occurred. It has auto-fused in a way. So now we have like 10 to 11 such cases. We are about to publish this where we just treat them with just percutaneous fixation with a biopsy percutaneously done in neurologically intact patients, sir.
Very nice.
Dr. Ahuja, do you have any experience on doing this type of technique, or you still do a biopsy first before you go for percutaneous?
It depends. This patient was relatively young, so if you look at this patient's scan CT, it doesn't look very dissimilar to the one I had shown. But unfortunately, Our Lady was much older, and more than that, she was quite way down the line because she had 3-4 operations before she came to us. So that I didn't feel comfortable just doing a segmental stabilization, like, level above, level below, or the level itself. I felt she needed more than that. And her bone quality, everything put together, just a single level stabilization may not have sufficed for her. But what's been shown is really good. It is something that you could consider. Like the bone destruction was quite a lot if you see on the CT, and that needs stabilization because that's quite a big gap to fill by just ankylosis once it settles down. So yes, there's absolutely a role for stabilization.
Yeah, so this is a newer modern technique. Rohan, has this been used in tuberculosis?
Yes, sir. So now we still do the same because I think tuberculosis basically would be a medical disease. So in neurologically intact patients with, some amount of instability, the idea is firstly, we usually offer conservative management till they come with a severely unstable spine and it's a single segment discitis basically. So then we can actually think of just putting in percutaneous screw and taking a biopsy via the transfacetal or the transpedicular route, whichever you're comfortable with, and then treat them with anti-tubercular drugs.
Usually in tuberculosis, we have already done the biopsy once. So would you like to take another biopsy if you're operating?
Yes,
that
sir,
is what I've seen in many surgeons here.
Always. But if you're going in, there's no harm because anyway, if you're doing something percutaneously, you might as well get that, or
So, Dr. Ahuja, coming back to post-operative infections. So, when do you see your patients? Means you have operated them. You may have seen them the next day or the day after before you discharge them. After that, when do you see them? When is a routine call-up? I'm talking about microdisc.
Yeah, they come back at 4 to 6 weeks. I would say about half to 60% get discharged at 6 weeks, and nearly 95% or more would get discharged at 3 months.
Okay.
So between 4 to 6 weeks and about 10 or 12 weeks, and like vast majority get discharged in the first 6 weeks itself once they're better.
Where does the suture removal happen?
We use dissolvable.
Acha, dissolvable. Okay.
We don't use any.
Yeah. So basically the patient basically, if he's asymptomatic, may not turn up to you for at least a month minimum.
Yeah. Yeah.
And if
Whereas,
he's having a little bit back pain, then he may, then it will
no, they're still being seen by the physios post-op.
Okay.
So what happens is from the ward, they get discharged to the physios. They get all their exercises and the physiotherapy protocols, the exercise program on the ward. They're doing all that. They see the physios in between. So within a month, they may have about 3 sessions or so. So if there's any queries in between, the physios can contact you, the patient can contact you. But vast majority, touch wood, as you know, most of them do so well.
Yeah.
You know, it's
So
such a good operation to do. Yeah, it's one of the most successful operations we do in a way.
In India, we say that if the patient has not turned you, if the patient has not come back to you, that means either he's completely fine or either he's gone to someplace else, and both is good.
Yeah.
But problem
usually they're fine.
Yeah, usually they are fine. But when basically the problem comes when they turn it to you late, that is 6 weeks. Instead of they should have come to you early, they come to you after 6 weeks or maybe 3 months. Then that is a big problem to solve.
But we have that fallback through the physio system, isn't it? Because they're saying, like, even if it is NHS or private, they do have physio follow-up.
Physiotherapist will report to you directly. They have access to you directly.
Yeah. If there's anything, they can contact you directly, and then we can work on that.
And then get the patient back in your system.
Absolutely, yes.
Okay.
Earlier.
So Agnivesh, do you have any more queries?
Yes, I have one question from the audience and one from myself. From the audience is that, Shashin sir, you talked about empirical combination of antibiotics.
Yeah.
You said 2 antibiotics. So they want to know that are those 2 sort of same gram positive, or you mix a gram positive and a gram negative cover antibiotic?
Because we usually have staff, and we just try to keep the cover broad. And I know in the past we used to rely quite a lot on Fluclox and Fusidic, which again mainly covers the gram positive, but others as well. But now we're going into a broader spectrum because we're using Fluclox, Fusidic, but generally our infectious diseases team would suggest using teicoplanin along with rifampicin here. So you invariably talk to them and they'll guide you. So Tyke is fairly broad spectrum, and rifampicin is a very good antibiotic. Actually, in your setup, it gets used a lot for TB. In our setup, it gets used for Pyogenic.
All right. And the second question is from my side is that how do you biopsy the cervical spine? These pyogenic infections, the CT people, how do they?
Our radiologists don't biopsy cervical for us.
Okay. So
yeah. So then we rely on the blood cultures, and then we start empirical treatment. But usually the blood cultures do show us something or the other. So blood culture surprisingly is quite a helpful tool in our practice.
All right. Dr. Rohan, you have any query? You have any questions you want to ask? Please unmute yourself.
No, sir. I'm fine.
All right. Darshan, you want to give us some insight about the cervical as well as lumbar pyogenic infections, what you encounter in your practice? So
No, nothing. I think I got answers.
All right. Neeraj sir, any input?
I think I have the one who's been asking the maximum. See, my personal interest is more in infection and osteoporosis. So whenever you see these lectures happening, I will be asking a lot of questions.
But infections is a silly one, isn't it? Especially after discectomy. Yeah. That's not one, although you consent the patient for infection, that's something that you don't want or don't expect usually.
So in my whole practice, in the last 5 years, I've seen 4 microdiscectomies getting infected. So basically, I am always worried. In fact, in so many, I would like to ask you one question which may not be related to infection. So in what case of a pure symptoms patient coming with pure symptoms of disc with no back pain, will you fuse instead of doing a microdiscectomy? Patient doesn't have any symptoms of back pain, where the MRI looks a little different, but patient still has only leg pain. Will you fuse only disc or no?
Why are you thinking of fusion if there
Avoid
is
the infection. To avoid the infection. I have actually done, basically when I got two infections,
right, okay.
I got two infections over a period of 3 months. I decided to fuse the next 2.
So I'll throw a question back at you. So what happens if they come with an adjacent level problem and have a disc prolapse at the level above?
That will come after 10 years. Then we'll look at it that way.
Fuse means, what do you do that time?
Fuse means basically postural, we put a cage and do a T-lift. Just remove the facet.
I thought you just put graft inside.
No, not graft. Basically put a cage, do a screw fixation, everything full, including the posterolateral and the cage, everything.
So Neeraj, the thing is, I would say, we don't do fusions here for back pain, right? I know certain areas, certain countries do a lot of fusion for back pain. We don't do fusion for back pain.
I'm talking about leg pain.
No, I know that. But because we've seen the problems of fusion with back pain, what can happen? And like adjacent level problems, pseudarthrosis, then you go anterior, then you do this, then you do that. Why do you want to get into that, right? A simple operation, a discectomy. I know you burnt your fingers, unfortunately. I hope you don't have any more in the next 5 years, because I think you had your quota. But see, yes, I would stick to what works and make sure it works well. And it does work well. You know it. And I'm sure you see it, all of us have seen in our practices.
He needs to change his spine surgery.
No, I think if you start having such things, usually they happen in crops, and that is the time your microbiologist and infectious disease specialist, they have to do a sort of thorough survey as what is causing it. Means you need to take the swabs from the OT, you need to check all the equipment, suctions, even the irrigation fluids which are coming. We once had a patient who did not have discitis, but had a pyrogenic reaction, sort of fever and all that when he was given IV fluid. It was a plain saline. When we sent it for culture, it grew staph. So I think all of these things you need to have a microbiologist or somebody from the infection team.
Happen in different hospitals.
No, I agree. I agree.
I'll just tell you what finally what I realized, what exactly happened and what went wrong. I realized I looked back at all the 4 patients, and there was one thing very common. They were on the bed in my hospital for 3 days. Okay, on a conservative management. In that conservative management, I had given them high dose steroids. So that was one problem. Second was, out of the 4 patients, 3 were from the slum areas. So their general hygiene conditions were not so great. So, and plus what I did not do is that overnight, after that I started doing is overnight scrubbing. Basically, do you use Dr. Ahuja? I don't know. So one night before we do a beta scrub and then cover it up with a sterile cloth. That we started doing. And after that, I've not got any spine infection.
No, I know, like, it's very different there and here, with due respect. As I said, I trained in Sign Hospital, and it was very different. Now, when we go and operate, when we do a charity work in Ahmedabad or in Chandigarh, when we do scoliosis surgery there, infection is something we dread. We absolutely dread. We will stay back and close the wound ourselves rather than anybody do it, because we don't want anybody to get infected. And fortunately, it's 2014 is when the first time we came down. We've not had infections. But I agree with you, everything, like, like Agnivesh says, like you said, everything. And even if that means thoda Ganga Jal Chidak do, that you don't get infection, I would do that. Simple as that. Sorry, you don't want infection, and you do everything possible. Yeah. And you've done the right thing. You had a crop of 4, you looked into it, you tried to analyze what the problem is, get to the bottom of it. And touch would be a very lucky here with the amount of infections we have post-operatively for metal work. Scoliosis surgery, over 17 years, I've only taken 1 patient back for a wound washout, and we've been fine, just closed it and it was okay. After that, I've not had any major issues. Like, we've treated really different pathologies, different underlying conditions, kids with all sorts of things, but we've been lucky so far. But I agree, that's something you dread the most, absolutely dread the most.
Because these post-op discitis don't become all right for a really long time. And they
You are
keep coming to you, keep coming to you. They sit in the OPD and they will bother other patients.
you're right. It's just that general. It's not just that area. Then it's the general feeling of being unwell.
Yeah.
That I agree with you. That's what you don't want, isn't it?
My query to both Session, Dr. Session as well as Agni, is your experience of getting staph most often your experience, or it is generally the case as per literature at all? How often do
No,
we use gram negative?
vast majority are staph. Like blood cultures will store staph. I've had a few strep, few E. coli, but vast majority are staph.
Yes, I think as sir said, vast majority are staph. The ones which are gram negative either have a sepsis which has happened with a gram negative, or they get it from the urinary. They have a concomitant urinary infection. They get it. And people who are immunocompromised or who are on dialysis or something, they can get a variety of bugs, even from like slow growing bacteria. You can get anything like E. coli, you can get concomitant 2 infections. It's a very, very vast scenario in that case.
Like the other thing we do is we don't touch the dressing at all. Like I don't even use drains for my discectomies. So once they have the dressing on, that stays for 10 days, 2 weeks, whatever it is. You don't touch them at all. There's no change. If there is no soiling of the dressing, you don't touch them at all. Just leave them.
And what about your post-op antibiotic protocol? Just 2 doses, 3 doses, and then stop?
I just give one more dose. So currently our protocols have changed. We're giving ceftriaxone and teicoplanin. That's the hospital policy. That's what we are following. I still give one more shot of kef or tyke after. I don't know. I'm still a little bit wary, although I might be contravening the normal guideline. I just don't. I having had two I had two virtually within a few months, and that shook me up a lot. I didn't have it for years. It's like a dural tear. Like
Yeah.
for 6-8 years, I didn't have a dural tear at all for primaries. I had one or two for revisions, and then suddenly over the next year, I had 2 or 3. I hate CSF. I hate a dural tear. If it takes another 5 minutes or 10 minutes, I'll make sure I take that much time more. Same, once you get this, then you're looking at everything. You're thinking about it all the time. It keeps bugging you. Even if the patient's not sitting outside to remind you, it keeps bugging you. Simple as that.
And plus, I think, see, what I'll talk about my infection again. So one more thing which I forgot to mention: my patients have not taken a bath for the last 3 days before they went in for surgery. I also evaluated that at least 3 out of the 4. So what is your take? Means, do the patient take a bath before they go in for surgery? Does this happen? How does this work in, because they get, I'm sure they're getting admitted at the hospital one day before.
No, I've never asked this question. Some of them in the private sector, the operation may be in the afternoon. They come at lunchtime. They don't get admitted in the morning or the.
In a bath and come anyways. Yeah.
I don't know. I've
You
never asked that.
Presume that. Yeah, at least you presume that they're taking a bath.
Yeah, no, I agree. But see, that is an important factor. See, that's what I'm trying to say. The way we work here and what we do here is slightly different to the way we work when we come to India and work. So you've got to make sure that everything is. Like I've remembered, as you said, patient gets scrubbed the night before and scrubbed in the morning and then go to theatre. I'm sure Sanjay will remember how things were in Sign Hospital when we were training. You scrub all the time. But yeah, that why did we do all that? Why all that effort so that you don't have infection? Because that's one of the most dreadful things that you can come across in your practice.
Okay. So I think we are done here. Agnivesh or Rohan, if you have any more queries, otherwise we can close the meeting.
No, I think it was an excellent session. It was an excellent talk by Shashin sir, and it's a very, very important topic for all of us. So before we close, may I ask Dr. Dhar sir to sort of give his final remarks, and then we can close. Dr. Neeraj sir, you can close the meeting then.
No, I'm thankful to you all for allowing me to be here. So nice of this session. In fact, when Agni mentioned, I suddenly jumped on it. I said, yeah, we should have him, because we have had so many webinars and so many things go on but I thought a new face, very well known here, but something new on the webinar. So it is a great opportunity to interact with you from your experience.
My pleasure, Sanjay, to catch up with you.
Thanks to Agni also for hosting this session. Agni is a very rapidly growing spine surgeon here. Displaced me. Thank you very much. Thanks to Rohan also for being here. Rohan is a very aggressive student of mine. Forces me to do all sorts of things which I dread. Anyway, thanks very much to all of you, and Neeraj obviously for hosting.
Okay.
Thank you very much.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you.
Thank you.